So, good evening. Welcome to the Unacademy. So, we now start with the NEET important topics in psychiatry. So, that is the always limelight. Every part is important, but if you see the recent trend, some topics are really very important in psychiatry, and we must know and appreciate them. And based on the previous years 5 years pattern of the NEET PG, the INI-CT NEET pattern. So welcome you all. Good evening, Dr. Mithu and Dr. Mahima. So, I have been teaching psychiatry for last 20 years, and that is trust me, the topics remain same. And that's brief about us at Unacademy. Presenting the NEET PG Vitals. Recorded videos for comprehensive NEET PG preparation. So they are the 800 hours plus of the comprehensive recorded classes for all 19 subjects. Exclusive content curated by expert faculties of the NEET PG. Comprises the clinical based question, previous year's MCQs and image based question. So master your conceptual understanding and ensure the excellent retention with graphs, flow chart and high yielding images from the top educators of the country. Now we have been All India medical test for the FMGE aspirant. So happening on 25th of June. 300 question and it will be 19 subjects. So you can enroll by using the code DR Sandeep 10 and it will be all free. And trust me, you can get a chance to win the 100% scholarship. But currently the aim is to check the level of your preparation. And the prices has been slashed. If you want to join the FMG test series to check your preparation level. So it's a 4 mini grand test, 1 ultimate grand test tailored to mimic the real exam experiences from 14th June to 30th June, and the price is only 1900. So these are all our team. Final Frontiers July 23. So available on the Unacademy. These are all the mentors we have here. And June 21st, the next ultimate concise batch having started, and we only have to pay only 7,600 again by using the code DR Sandeep 10. So for FMG also 1.5 month course, again made by the top educators for only 4,000 rupees, something less than 4,000, 3,799. So good evening Dr. Ritu, Dr. Ankita and Dr. Mahima. So again this is the same, double ho gaya. So what we see in the pattern, I have gone through all the papers of last 5-10 years. Mostly now the psychiatry is focusing on the detailed MMSC, detailed MSc also, mental state examination also. A lot of MCQs we have seen in the recent past from the thought, from the perception, about the force thinking. So many are there. And talk about DSM, ICD, ECTs and the RTMS. About the complication of psychiatry, that Wernicke's and Korsakoff syndrome, lithium and valproate were the loving drugs, and the SSRI. So all the drugs, their mechanism of action and their side effects are being very loving topics of the examiners. And the delirium, of course. So these were the loving topics, and therapies for OCDs and phobia, and the the delirium. So I have seen delirium and the delirium tremens. So one side effect and one the new thing. So that is the question trend usually we have. Now to learn it, we have the okay. So, but let's see that questions trend that were being asked in the examination. We have a list of the topics. I have seen that there is a question from the panic attack, question from the alcohol Korsakoff psychosis, close up in side effect, and general understanding that what to do when in the therapy. So first question we have B is the eating disorder. Well done, Dr. Well done, Dr. Priyanka, Dr. Ritu, Ankita Pandya, Dr. Shakur, Dr. Senthil, and Dr. Sehal and Dr. B. Well done. So so we see that the eating disorders are more common in the women. Depression, anxiety, specific phobia, and so on. That's a list. In men, there is autism, early onset schizophrenia, antisocial personality and conduct disorder, and the alcoholism. So PTSD, eating disorder, suicidal attempt are more common in the women. So these are the list and these are the points. Now, percentage of suicidal death in schizophrenia includes. So we know that the most common cause of suicide is the depression. And we know that the most common phase of it is 10%. It is 10% here. So most common phase of depression, most common phase of depression for suicide is the depression in recovery, and we call it as a paradoxical suicide. Paradox here is that's a question also, if you remember. So a lot of suicidal MCQs have been asked in the previous years. So see, it's logic. Psychiatric emergency, psychiatric medication side effect, some main topic like schizophrenia, mood disorder, and OCD, the basic conceptual MCQ, then the question from the mental state examination, and the basic concept of psychiatry. Okay. And that's this. So we know the most common age and gender worldwide for suicide is the worldwide. It's elderly men. In India, it's 18 to 29 year old age. Most common age. So that is a teenage. Very good, Dr. Saab. Yeah. Depression and recovery matlab when the depression is improving. So that's a common queries we all have. See, when I am in depression, I really want to kill myself. But railway track is so far, fan is so high, how can I kill myself? I can't plan suicide because of depression. My cognition, my motor activity, all has been decreased. But once my depression start recovering, my core cognition is still to die, but I got the power to plan for suicide. I know I can hire a Ola Uber cab and go to railway track and kill myself. I can put a table beneath and hang myself. So I got a better plan to do that. So that's a paradox, that though the depression is improving, but there is a suicidal tendency is increasing. So that's a paradoxical suicide. Suicide is a significant risk factor for patient of schizophrenia and approximately 10 years of people. Most of people, they come do suicide because the despair and depression, or in response to the command hallucination or the persecutory delusion. So maybe due to the distress or depression, or in response to the command hallucination or persecutory delusion. In schizophrenia, the reason is that. Now MMSC, we know it's a mini mental status examination. It is a basic clinical tool for the bedside evaluation of memory. Okay. So the maximum score is given for we know total score of this is the 30. Cutoff score is less than 24. It's a orientation. It's very good. No, recall is only 3. Recall is only 3. That's a. So it's a. Yeah. So we just see. So it's a 5 areas of cognitive function: orientation, registration, attention calculation, recall, and language. The maximum score is 30, and it's a Folstein's test to measure the cognitive impairment, measuring the orientation and so on. And that is the complete scale. Orientation to time, orientation to the place, registration, recall, 3 number, spelling of the word backward, and subtracting 7 from 100. Language is 2 and repetition is 1 and command is the 6. So these are the possible points for the MMSC. So that's a. Now visual hallucinations are being commonly seen in. We just have a look at this question also. Not a paranoid symptom. So it's basically a question testing the basic understanding of the psychopathology. Paranoid in English means suspiciousness, but paranoid in psychiatry is a umbrella term for delusion. Umbrella term for the delusion. Very good. So all delusion, whether persecutory, infidelity, grandeur, will be labeled as a paranoid. And thought alienation being a different category. No. Answer is the D. So whether it's any delusion, persecution, infidelity, grandeur, the term will be the paranoid. Thought alienation will be like a disorder of thought. It's different from the paranoid. So answer will be the D, not B. That's a. So paranoid in psychiatry is a umbrella term for all delusions. So this is a brief about the. Now visual hallucinations are being commonly found in the. So visual hallucinations can be seen in the FTD, PSP, and some staging in the Alzheimer's disease. But the question क्या है डॉक्टर साहब? That usually seen in the Lewy body dementia. It's commonly seen in the Lewy body dementia. नहीं डॉक्टर साहब, FTD में नहीं होता. Not very common because yes, can be seen in the FTD, but yes, very less. So it's a second most common form of dementia after dementia of Alzheimer's types. Prominent symptom like Parkinsonism, visual hallucination and cognitive fluctuation. So basically the memory lapses are not that very prominent. Presently, mostly the patient come with the visual hallucination or some movement disorder. And the characteristic and hallmark is the cognitive fluctuations. And more than 20% of the patient diagnosed with, so that is the hallmark. In the FTD, that's not very common. Okay. They may have an insight. They may have a, so that's visual hallucination, an important clinical clue indicating that dementia may be Lewy body rather than the another subtype of dementia. Varnaceline has not been used commonly. So again I tell you that it's some medication side effect they'll ask you. Varnaceline, we all know it's a partial nicotine agonist. So her exam में डॉक्टर साहब, it's act on the alpha 4 beta 2 subunit of the nicotine receptor and starting in a dose of 0.5 given ultimately 1 mg BD. Suicidation as a side effect. Treatment is given for the 24 weeks. So 12 weeks plus 12 weeks. Usually treatment is for. So false is that the C. So it can lead to the, well done Dr. Mittu. Yeah. So treatment is given for the 6 week only. We just have a look that it's used to treat the nicotine addiction. Displays a full antagonism to this and partial agonist to the alpha 4 beta 2. It's beta. Okay. So that lead to the smoking cessation. And the starting regime is a 0.5 milligram once a day, then BD, then 1 mg BD, and for 12 weeks, and then 12 weeks 1 mg 12 hourly. And serious psychiatric adverse events, so it is now the drug withdrawn from the Indian market. So it's a psychosis, hallucination, paranoia, delusions, and so on, and also lead to the anxiety, suicidal and the homicidal ideation, attempt, and the somnambulism. So somehow it is playing with the other neurotransmitter of the brain and can lead to all these symptoms. A person hears a voice before falling asleep. History of fall in a daytime sleep attack. Probable diagnosis is. It's a beautiful way to ask the narcolepsy is one of the topic, Dr. Saab, which has been uplifted like anything in psychiatry. तो साइकेट्री में किसी टॉपिक से सबसे ज़्यादा अपग्रेडिंग एमसीक्यू आए हैं. देखिए हम क्या बात करते हैं कि प्रीवियस ईयर्स एमसीक्यू इंपॉर्टेंट नहीं है, प्रीवियस ईयर्स टॉपिक इंपॉर्टेंट है. सो नार्कोलेप्सी आई थिंक इज द बेस्ट एग्जांपल ऑफ द topic which is called previous year's topic. So lot of MCQs has been asked in an upgraded manner from narcolepsy. Well done Dr. Saab. Vikram ji. Anybody else? So answer is A. So narcolepsy is a loved topic of the examiner. So to regulate the sleep wake cycle excessive daytime sleepiness and seconds to minute and may occur at any time. Episodes of sudden loss of muscle strength and can be brought by the sudden strong emotions. Tetrad of narcolepsy is sleep attack, sleep paralysis, cataplexy, hypnagogic hallucination while going to sleep, and hypnopompic hallucination while waking up from sleep, and excessive daytime sleepiness. So that's the Khali Vikram ji ne kara, Dr. Sahab. Nobody wants to say that. Okay. So if you remember that narcolepsy MCQ, it is been categorized now as a type 1 and type 2. Type 1 is a idiopathic, associated with the major histocompatibility complex HLA-DR2. There is a loss of the hypocretin or orexin producing neurons in the hypothalamus. So आपको याद हो डॉक्टर साहब, पहले they ask you the MCQ that the tetrad of narcolepsy is sleep attack, sleep paralysis, and then they ask you the pentad. Pentad was the abnormal intrusion of the REM in the EEG. Then they gone to the area of the brain involved is the hypothalamus. Next level they gone to the chemical lag is the hypocretin. So it is associated with the cataplexy and rest all tetrad. Type 2 is usually the post-traumatic, post-meningitis, not associated with the cataplexy. तो इसमें cataplexy नहीं होता है. So narcolepsy has seen the real, the which we say that it's not the previous year's question which is important, it's a previous year's topic. So from tetrad to pentad to sleeping to hypothalamus to hypocretin to type 1, type 2, association with the MHC, major histocompatibility complex, and then the drug of choice was methylphenidate. And now answer is modafinil. So from that level, डॉक्टर साहब मोडाफिनिल अभी ड्रग ऑफ चॉइस है, पहले द ड्रग ऑफ चॉइस वाज मिथाइलफेनिडेट. आई एम टेलिंग यू सो बिकॉज देयर इज एन एमसीक्यू इन द चाइल्ड साइकियाट्री that a drug which can treat both narcolepsy and ADHD is methylphenidate. Okay. Now, how would a diagnosis of the agoraphobia is made? So that's basic about the insomnia, left alone, open space, and that's. Agoraphobia we know is a psychiatric term where there is a fear of places from where easy escape is not possible. It could be a open space, it could be a closed space. So in psychiatry, so answer will be the B. But in psychiatry, whether it is a dark place, crowded place, called ankylophobia. So in psychiatry, they say that for any place phobia, whether it is closed, open, dark, crowded, we only have one diagnosis in psychiatry when it's called agoraphobia. It is of two types. Without panic attack, so panic attack is not a mandatory for it. Without panic attack, and agoraphobia with panic attack. Agoraphobia with panic attack. No, not all. People are doing wonders. That's up. Open spaces, closed spaces, lift, everybody is moving. But if it is associated with a panic attack, that will be the more sure shot of a agoraphobia and its severity. So that's some name: stealing, speaking, lysophobia of rabies. Okay, and that's an English name. That's all English name. That's how. Just we, son ka heliophobia, woman ka gynophobia, and so on. But marriage is a gamophobia. So that's all the multiple names, but that's all English language. In psychiatry, for any place phobia, it is the agoraphobia, with and without panic attack. So such a huge list in English. Okay, difficult to remember. Okay. Yes. Now again, marijuana or any substance abuse. Alcohol has been loving one, but I have been going through that in some examination. We have the for the addiction, opioids. So it's a cannabis has been first time been taken as a drug with the both physical and psychological dependence. So as per DSM-5 and ICD-11. So cannabis has both. That's the answer is the irritability. That's why I would say let's go for the DSM-5. The ICD only one guideline is different. Otherwise, usually the ICD and DSM are all same. In schizophrenia only, as per DSM-5 for schizophrenia, it is more than 6 months. Otherwise, though, almost all have a same guideline. That's all. More than 1 month for schizophrenia. But since we always ask about the schizophreniform disorder, in PGI they have a lot of MCQ about the schizophreniform disorder, which is a presence of delusion and hallucination for 1 to 6 months. So I would say let's take the DSM-4. वो आपसे इतना गहरा सवाल नहीं पूछेंगे डॉक्टर साहब. They will not ask you usually. For depression, for mania, for hypomania, for OCD, for phobias, it's all similar. Only for schizophrenia there is a difference. Okay, otherwise I don't think so. They'll ask you because most of the good language understanding is written in the DSM-5. ICD-11 is totally difficult to understand, and it's very very computer type. Like they're written like as if they are doing human brain as a computer. So just like mechanical, not understanding the concept of the nature of psychiatry. Okay. So cannabis has both now the physical and psychological dependence. Before the DSM-5, it has been seen that it only have the psychological dependence. So irritability, poor appetite, lack of motivation seems to be the common withdrawal symptom. So mild forms may experience minor physical or psychological discomfort, headache or restlessness. Severe forms may endure more intense withdrawal symptoms including sweating, fever, chills and hallucination. So these are the physical symptoms: stomach discomfort, sweating, tremor, chills, fever, headache, and irritability, anxiety, depression, restlessness, insomnia are the psychological, again, the symptoms. So these are the first day is the irritability, anxiety and insomnia. So craving can be strong, and that's all. Now lithium has been the loving topic. I have been going through in the AIMS, PGI and JIPMER. So 2020 में AIMS में there were 2 questions, PGI there was 1 question, and in JIPMER also 1 question from the lithium side effect and toxicity. So lithium is a loving drug. They asked you when should we check the lithium levels? After 5 days, within 12 hours of last dose. Not a side effect, डॉक्टर साहब. बशीर साहब देखिए, it has a side effect of leukocytosis, commonly used in the leukemia, to increase the WBC count. Yes, Dr. Ritu and Dr. Akansha Agarwal. So we know lithium is a drug with the narrow therapeutic index, and therapeutic level of lithium is 0.8 to 1.2 milliequivalent per liter. Anything beyond 1.5 milliequivalent per liter is a toxicity. So it's a drug. Well done. Welcome, Dr. Sahu. So, and the side effect also is important. So they asked you everything. So lithium तो पक्का याद करना है हमको. Side effect are the tremors, hypothyroidism, leukocytosis and diabetes insipidus. Toxic, again we have the tremors, we have the nystagmus, brisk reflexes, ataxia, seizure, coma and death. And we know the side effect are the fine tremors. Here it's a coarse tremors. For prophylaxis, it is 0.5 to 0.8 milliequivalent per liter. Yes, lithium is contraindicated in pregnancy as it can lead to the Epstein anomaly. So that's all about the lithium. So lithium toxicity usually precipitated by, it's 1.5. Toxicity usually precipitated by gastroenteritis. So these are the polydipsia, polyuria and nephrotic syndrome and so on. Such a long list. Now again we have to learn the side effects, so we have to be correctly matched most common side effect except clozapine usually cause, clozapine we all know usually cause the sialorrhea. Mirtazapine can cause. So I would say the correctly matched most common side effect is the sertraline. it can lead to delayed ejaculation. We know bupropion and mirtazapine are the two antidepressant without any sexual side effect. Clozapine causes the sialorrhea and sedation. Agranulocytosis usually happen in the correctly matched, Dr. Sahab. So correctly matched is the sertraline and delayed ejaculation. We know all the SSRI has a side effect of the delayed ejaculation. Now trichotillomania. It's a set fire is a pyromania, kleptomania. Again, it's an impulse control disorder. True about is that associated, except that, sir. Oh, sorry. Yes, sorry. Then the answer will be the that will be difficult. Clozapine thereby usually cause the bupropion can't have a side effect like that. So we have to be master of the confused. Yes. Answer is A. Yes. So mirtazapine can cause akathisia. Bupropion is a sexually neutral medicine but may have premature ejaculation, and that's all. So sorry for this. Yes, thank you so much, Dr. Sahab, for correcting. So that's great. So good teamwork. A is the answer. Very good, Dr. Sahab. Sorry for this. Yes, except is asked. My mistake. Now trichotillomania, you say it is C. Yes, it's a. We know it's a impulses to pull out. So classified with the impulse control disorder in DSM-4, classified now in DSM-5 with OCD and related disorders. In DSM-3, placed under body focused repetitive behaviors. So if you remember in the last exam, so there is such a topic remains same, the trichotillomania. So once they ask you trichotillomania, we must know it was impulse control disorder, currently been classified as a OCD. Previously it is called as a BFRB, habit, under the heading of the habit disorder. It was classified as a body focused repetitive behavior. So that's a question they ask you. A psychiatric illness previously been classified as a BFRB, now been categorized as a OCD. So that's a conceptual understanding of the question. So schizophrenia has been a loving topic of psychiatry. So we must not be missing the good and the poor prognostic table. So the better prognosis is with the except. All are the better prognosis except the no. negative symptom. Somebody married, late age of onset, acute onset are the poor prognosis. Okay. So we all know that acute onset usually after a precipitating event, predominantly positive symptom, no family history, emotions are being preserved, no CT scan MRI finding, somebody married, female, late age of onset, that is after 45 years of age, is a complete table for the, and a family history of mood disorder is a complete table for the good prognosis of schizophrenia. Acute onset usually after a preceding event, predominantly positive symptom, no family history, emotion being preserved without any CT scan MRI finding, married, female, gender, late age of onset, and we know that's again MCQ, that what is the late age of onset. So it's a onset after 45 years of age, and family history of mood disorders. Poor will be the gradual onset, slow onset. As such, there is no precipitating event, predominantly negative symptom, family history is also positive, some CT scan MRI finding present, some CT scan MRI finding, and it's a presence of the soft neurological signs and somebody having a schizoid personality beforehand. So late onset is a good prognosis, Datsa. Okay, that's a complete table for the good and the bad prognosis. So that's again one of the MCQs they never miss in the examination about the schizophrenia, good and the poor prognosis, or first rank symptom, or so on. Sometimes they go to the basics, and transitional object is seen between the ages of the 6 months to 1 year. So it's a comfort object or security blanket. So it's usually, especially they provide the unique situation, especially in the unusual or unique situation or at bedtime of child. Among toddlers, comfort object may take a form of blanket, stuffed animal, or a favorite toy. And transitional object usually seen between the ages of the 6 months to 1 year. So that's again and again we are talking that. Now again a topic about the suicide risk factor assessment. Which of the following is not included in the? So we know that hopelessness is the major paradigm. It is the symptom of depression which is the most associated with the suicide. Again, insomnia also can lead to increased risk for suicide. Social isolation, substance abuse increase the vulnerability for the suicide. Again, the high anxiety, panic. So the answer will be the none. Very good, Dr. Snowcast. Doctor. It's a none. So all are the high risk factors for the suicide. Very high risk factor for the suicide. ठीक है डॉक्टर साहब. But other than the suicidal risk factors, we must also focus on the what actually can prevent suicide. So rather than focusing what can lead to suicide, we must also think of what can be the protective factors. So life satisfaction, social support and social belongingness, sense of responsibility to the family, good coping skills, problem solving skills, strong therapeutic relationship, and reality testing ability and religious faith can prevent the suicide. Okay. Again, then one talk about the psychiatric overdose. A patient on treatment for psychiatric disorders take a overdose of a drug, develops bradycardia, hypertension, decreased sweating. This drug is बताइए डॉक्टर साहब. This drug is the amitriptyline. This drug is the amitriptyline. We know TCA overdose can cause death. By cardiac arrhythmia. Okay. But before I die, there are two steps where you can intervene. There is a widening of the QRS interval. You can give me the sodium bicarbonate. There is a QTC prolongation. DC shock. Atropine can be given. Yeah. Yes. Now, adjustment disorder. False is that the basic definition. False is the D. May be required adjustment disorder, but by definition we can say both. Invariably का जरूरत नहीं है डॉक्टर साहब. It's a illness which should start within 2 weeks to 3 months of stressful event, resolve by its own within 6 months. So if we go by definition, yes, we can provide the psychotherapy, we can do the group therapy, and it's not a permanent condition, it's usually a temporary condition which improves by its own. But yes, we can shorten the duration. So that's a concept about the adjustment disorder. Now, obsessive compulsive disorder. The brain areas involved with the OCD include all except claustrum, or orbitofrontal cortex? Difficult question it is. Usually in psychiatry we don't talk and touch upon such topics. So basically it's a claustrum. So we know that orbitofrontal cortex, basal ganglia and head cortex nucleus are the predominant structure involved in the OCD. So OFC, ACC, head of cortex nucleus. They are hyperactive at rest, increasingly active with symptom provocation, and no longer exhibit the hyperactivity following the successful treatment. So these are the reasons they say the hyperactivity can be decreased by the medication, also by latest technology of the transcranial magnetic stimulation. So answer is the A. Yes. Delirium. Yes. Delirium is another favorite topic of the examiner. We know it's another name for the acute confusional state. True statement is that there is a decreased attention. There is no clear consciousness. It's usually reversible. It's a sudden onset. Attention is decreased. Well done, Doctor and Dr. Ritu. It's a insidious onset, ये गलत है. So we know it's a orientation is impaired. In this the orientation is impaired. It's a reversible. That's how it is not irreversible. If you treat the cause, treatment is treat the cause. Whatever the cause may be, oxygen less, CO2 more, electrolyte imbalance, infection, whatever is the cause, you just treat the cause, it will be taken away. In this the orientation is, it's a reversible. Delirium is a reversible condition. Orientation is impaired. There is a visual hallucination. There is a transient delusion. There is a reversal of sleep-wake cycle. There is a sundowning phenomena. More of confusion, more of hallucination after sunset. It's either hyper or hypoactive delirium. And there is a picking behavior called as flocculations, as if they are trying to catch hold something in the air. Okay. Treatment is treat the cause, but till the time you treat the cause, you may give the injection haloperidol. And now the latest question they ask you is chemical responsible for delirium is the choline. Cholinergic loss led to the, somehow the choline got lost, and that is what leading to the delirium. Now Wernicke-Korsakoff syndrome is another loving MCQ of the examiner of the NEET PG. It's a chronic alcohol abuse characterized by the all of the following symptom except. So if you see, lot of MCQs has been asked in the previous. I was seeing there are 3-4 MCQs about the alcohol and this Wernicke-Korsakoff psychosis. देखिए डॉक्टर साहब psychiatry में nothing much is serious. The irreversible are Alzheimer's disease, life-threatening are delirium and delirium tremens, and then the Wernicke-Korsakoff syndrome, where at least we can do by identifying. The moment you give the thiamine, this process will be reverted back. So confabulation, loss of remote memory is wrong. So in this we have the recent memory loss plus confabulation. Nystagmus and paralysis of the, इसका डी पूछा डॉक्टर साहब, डॉक्टर स्नोकास्ट, इसका डी या इसका डी. In Wernicke's encephalopathy, we know it's an acute condition. Korsakoff is a chronic condition with a memory loss. It's an acute reaction to severe thiamine deficiency. Commonest cause being the chronic alcohol use. Characteristically, usually start after the period of vomiting, and signs are ocular signs remaining from coarse nystagmus to ophthalmoplegia with bilateral extraction palsy, pupillary irregularities, papilledema, retinal hemorrhage, and so on. Higher mental function disturbances are disorientation, ataxia, confusion, and the changes are seen in the neuronal degeneration are in the thalamus, hypothalamus, and mammillary bodies. Confabulation is filling up of a memory gap. You ask me what you have taken in the breakfast. I don't remember what I have taken in the breakfast, but the moment you ask me, I tell you I have taken the idli vada. Idli vada I have taken 3 months ago when I was in Chennai. So I filled up the gap of my memory from my previous information. So that's a confabulation. Filling up of a memory gap. Recent memory loss, I don't remember what I have on breakfast today, and I fill up with something story. If my family is not around, you will be confused whether I am telling true or right or wrong. Okay, that's all. Shakur sahab ho gaya. Confabulation, it means the filling up of a memory gap. So that's some questions to understand. These are MCQs from JIPMER. So topic remains the same. Police by exposing himself nude. So most likely there is no history. So maybe it's a seizure. Absent seizure, it could be leading to the such behavior. But 67-year-old man hai, so it could be the Alzheimer's disease because of disinhibited behavior. Includes the seizure or Alzheimer's disease, or maybe some intracranial tumor. The frontal lobe tumor can lead to the disinhibited behavior. Cocaine addiction may manifest as. Cocaine, we all know, it increases the all amines. So increased dopamine may lead to the severe anxiety and paranoid delusions. A may be manifested as a borderline personality include so no empathy in a relationship, either black and white view, either idolizes or so exhibit the signs of strong desire for attention. That will be in the histrionic personality. Organic anxiety can be all of the above. Pheochromocytoma, all can be the cause. We all know A, B, C, D. All can lead to the heightened anxiety state. Antisocial personality disorder, we all know these people have a no guilt, no empathy. So it could be both. Lack guilt conscious, maybe this D. That's all. They fail to learn from past mistake. Extreme sense of rights. So, somatization disorder or chronic neurosis. So, it's all of the above. Excessive use of drug, they go to multiple dependence on the healthcare physician. They do doctor shopping, we know they do the doctor shopping. Hospital addiction, and just to know the diagnosis. कि डॉक्टर साहब बीमारी तो बताओ, please tell me what is my diagnosis. So they come to us with a multiple symptom and so on. Malingering differ from, it's a simple thing that it's a does not a psychiatric illness. So with this, we thank you so much for actively joining with us, with a promise that topics which we have to focus is the drugs of psychiatry, OCD, mania, schizophrenia, सारी हो जाएंगे डॉक्टर साहब. Concept of the personality, some medication and their side effect, and latest treatment, along with the delirium is a loving topic and the MSc. So with this, I thank you so much for joining with us and hope you will enjoy psychiatry at NEET PG Vitals or any YouTube or special classes at Unacademy. Thank you again. Good night. Thank you for joining.